So today we're talking about blood flow through the heart, intrinsic innervation as well as extrinsic innervation of the heart, how that's represented on a basic EKG on the far right, and then S1, S2 heart sounds as well as S3 and S4 heart sounds. So a good quick cardiac review for you guys. So this is a depiction of the heart. The blue side is the right side of the heart because it's carrying deoxygenated blood. Right atrium, right ventricle. Red is the left side of the heart, left atrium, left ventricle. We can see our valves there. So we'll talk briefly about the blood flow through the heart. So we need to know where's blood coming into the right atrium. What's bringing that blood in from the right atrium? Okay, so that's going to be superior vena cava, so your SVC, that's bringing venous blood in from the head, neck, and upper extremities. IVC, it's bringing venous return in from the lower extremities and trunk. Okay, and we also have this little structure here, made a little opening. That's representing the coronary sinus. So remember, the coronary arteries bring oxygenated blood to the myocardium, the muscle wall of the heart, but then the venous return bringing the deoxygenated blood from the myocardium. All those cardiac veins drain into the coronary sinus, which drains into the right atrium, right? Because we still need to bring that deoxygenated blood back into the heart. Okay, so three structures that drain into the right atrium: your superior vena cava, inferior vena cava, coronary sinus. Okay, blood from there travels to the right ventricle. So we have that's injecting blood during systole into the pulmonary trunk, which then splits into the right and left pulmonary arteries. Okay, so this would be we'll call this your right pulmonary artery. And this over here would be our left pulmonary artery. Okay, and this is your pulmonary trunk right here. Okay, so that's where deoxygenated blood is ejected from the heart and sent to the lungs via the pulmonary arteries. So blood's returning. So how does blood return back to the heart? Well, it's returning through pulmonary veins. So we show two on the right, two on the left. Okay, so these are our pulmonary veins. We'll put two V's for veins because there's two of them. Pulmonary veins. Okay, so here's your left atrium. So we see four openings. Okay, two for the left pulmonary veins, two for the right pulmonary veins. So remember, this is the best depiction of the heart you can draw, right? But in an actual heart, the left atrium is more in the posterior aspect of the heart, right? So it's behind a lot of other structures. So the pulmonary veins are bringing blood back to it. So the right pulmonary veins, you can see, are going posterior to the heart and draining through these openings into the left atrium. Okay, so the pulmonary veins are bringing oxygenated blood back from the lungs, right? Picked up oxygen, dropped off CO2, back to the left atrium. So left atrium is going to travel through the mitral valve, left ventricle through the aortic valve into the aorta. You can see the aorta there. Okay, this big ascending aortic arch, and it'll go into the descending aorta. So we'll just call it the aorta. Okay. And this is also important, so we know when you listen to the heart valves. You're going to learn this later. When you listen to the heart valves, remember we're going to listen in the right second intercostal space, so the right side of the sternum, right? We're not listening to the pulmonic valve because we think, it's on the right side of the heart. We're listening to the aortic valve. Okay, so the aortic valve we're going to listen to in the right second intercostal space. The pulmonic valve is going to be in the left second intercostal space. Okay. And we can see that there. So trying to make that depicting that properly. Okay, so this is the order of the heart where blood's going to flow. Okay, so now what actually happens, right? So we know during diastole. So what's happening during diastole? So diastole, the heart is relaxed and the heart is filling. Okay, so we can squeeze this in here, I guess, and then right here. So in diastole, the heart's filling, right? Diastole, the heart's filling, okay? So what valves are open, what valves are closed? So during most of diastole, right, the aortic valve is closed, the pulmonic valve are closed, right? Those are your semilunar valves. Those are closed. Blood's not leaving the heart's filling with blood, okay? So then our tricuspid and our mitral valves will be open. So blood's flowing into the atria and then into the ventricles, okay? So on the right side of the heart, blood's flowing through the SVC, IVC, coronary sinus, into the right atrium, and it's flowing into the right ventricle, and glug, 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 it's filling up from the inferior aspect upward, okay? On the left side of the heart, blood's coming back to the pulmonary veins and draining blood into the left atrium, which is then filling up the left ventricle, and blood is filling up, okay? So early in diastole, the heart's filling, tricuspid mitral valves are open, okay? And the semilunar valves, so if you want to draw that these are closed, so these valves will be closed. We don't want blood leaving the heart, right? The heart needs to relax to fill. That's why in cases where your heart rate gets really fast, like in supraventricular tachycardia, as your heart rate's 250, beats per minute, the heart's beating so fast, it can't relax enough to fill with blood. If the heart can't fill with the blood, it can't pump the blood. Another example would be left ventricular hypertrophy. So if someone has significantly hypertrophied their heart, well, the heart can't grow outward, only so much because it's in the pericardial sac, the heart's going to grow inward, right? So this is going to get smaller. So left ventricle is going to get smaller, okay? So if that chamber's smaller, it physically can't fill with enough blood. So if it can't fill with that blood, it can't pump that blood, okay? This is early in diastole, okay? This is early diastole. So, and then what happens towards late diastole? So the heart's filling, right? It's filling up. So we're going to start our atrial contraction, right? Atria are going to contract. So why are they going to contract? So we're going to put this all together. So your SA node, right? Your SA node spontaneously depolarizes. So we know the SA node has leaky sodium channels. So leaky sodium channels, or we call them funny sodium channels, and they depolarize very easily, okay? So remember your heart, all the black I depicted here, these black lines are all the intrinsic conduction system of the heart. The red is the vagus nerve, the parasympathetic innervation, which is extrinsic. Green, those are green fibers that are extrinsic as well, depicting the sympathetic nervous system. So barring those, this is the intrinsic conduction system of the heart. So the SA node will spontaneously depolarize due to leaky sodium channels, and about 60 to 80 times per minute, it's going to depolarize, and it's going to send a signal through the heart as long as the conduction system is working properly. So the heart's filling between depolarizations of the SA node, okay? Now the SA node is going to depolarize. So when it depolarizes, it carries its conduction signal through the left atrium via the Bachmann's bundles, and then through all these internodal fibers that go through the right atrium, and then it ends at the AV node where we have a delay, okay? So we'll stop there. So SA node depolarizes, carries the signal through Bachmann's bundle to left atrium, all these internodal fibers, and the atria contract. So if the atria are contracting, they're pushing all their blood into the left ventricles, right? We want to push as much atrial blood into the ventricles as possible. We call that atrial kick. So that last contraction of the atria pushing all that blood in, we call it atrial kick because it's filling those ventricles as much as we can with blood. So if we have a arrhythmia like atrial fibrillation or even maybe atrial flutter where the atria aren't contracting properly and we lose atrial kick, we can lose like 20 to 30% of cardiac output potentially. So we can lose a decent percentage of cardiac output because the atria aren't fully pushing all their blood into the ventricles. Okay? So, atria depolarize, what happens? They contract, they push all their blood into the ventricles. When they depolarize through this part of the intrinsic conduction system, that is depicted by the P wave on a very basic EKG. So electrodes on the chest wall, they pick up the electrical activity through this system, and it's going to be a little P wave. Okay, so that's depicting atrial depolarization. So the P wave is atrial depolarization. So atria contract, and what they do, they push all their blood into the ventricles, and then right after that happens, the valves, the AV valves shut. Okay, so what happens? These AV valves, so the tricuspid valve on the right shuts, and then the mitral valve in the left shuts. So these atrioventricular valves shut. Okay, and when those valves shut, it creates the S1 heart sound. Okay, so S1 heart sound. So S1 is AV valves closing. And ideally, they're snapping shut at the same time. It's not a split S1, it's a normal S1. So after the atria contract, they push all their blood in the ventricles. So why haven't the ventricles contracted yet? Because the AV node. So we know there's a delay at the AV node of 1/10 of a second, but really it's 0.12 to 0.2 seconds, okay? And that's what's depicted by this, our PR interval, right? That's why we have a PR interval. So that's because the AV node has a delay. So this should be between 0.12 to 0.2 seconds, okay? So in your EKG, if you have a greater gap than that, it could be heart block, okay? There's first, second, third degree heart block. So if you have a delay just longer than it should be, that could be a first degree heart block. Okay, so the AV node provides that delay, which is important so the atria can have the atrial kick and push all the atrial blood into the ventricles, or most of it, before the ventricles contract. Okay, so that happens late in diastole. So early diastole, the heart's filling, AV valves are open, semilunar valves are closed. Late in diastole, the atria contract, AV valves are closed, and the semilunar valves are closed as well. Okay, so you could break that down to early diastole and late diastole. So you could say early diastole. So early diastole, AV valves open, SL valves are closed. When we get into late diastole, right? So late diastole, so atrial, we had atrial systole, basically the atria contracted. So AV valves are closed, and your semilunar valves are closed. Okay, so now the ventricles have to contract. And remember, to open all these valves, it's all due to pressure differential. So for the pulmonic valve to open, the pressure in the right ventricle has to overcome the pressure in the pulmonary trunk, okay? For the left ventricle, right, so for the aortic valve to open, the pressure in the left ventricle has to overcome the pressure in the aorta, okay? So if you have high diastolic blood pressure, you have a high afterload, this left ventricle is going to contract extra hard to pop that aortic valve open and get blood flowing in the aorta to the body. So if you think about that, if you have high blood pressure, not hour after hour, day after day, month, year, even if you're sleeping, it's high, well, that left ventricle is working extra hard all the time to pump against that, okay? Obviously, your blood pressure goes up when you exercise, but that's not 24/7. So very elite athletes, they can get left ventricular hypertrophy, but it's mild. They have a very healthy heart, okay? Something that's pathologic is when you have heart failure, and one of the causes of that is chronic uncontrolled hypertension because that left ventricle has been working hard for many, many years, okay, and it gives out, okay? So anyway, we have to overcome the afterload, overcome that pressure, so for those valves to open, okay? So now the ventricles start contracting. So we take the conduction pathway from the AV node to the bundle of His, which splits into the RBB and the LBB. RBB is the right bundle branch, LBB is the left bundle branch, and that's carried by these Purkinje fibers along the walls of the ventricles. So it's carrying that electrical signal through the ventricles. That's ventricular depolarization. And that's depicted on your basic EKG by the QRS complex. So that's ventricular depolarization, the QRS complex. Okay? So when that happens, the ventricles contract until the pressure overcomes what's on the other side of the semilunar valves, and the semilunar valves pop open. Okay? So the semilunar valves open up. It's time to eject blood from the heart. These are great depictions of heart valves here. So then they contract and blood goes into the pulmonary trunk, to the pulmonary arteries, which is going to the lungs, and then blood goes into the aorta, which is going to take blood everywhere. Okay. Remember, the first branch is off the aorta, the coronary arteries. It's always a common question to remember, okay? So that's during systole. So systole, So in systole, the ventricles contract, the AV valves stay closed, but once we hit enough pressure to open the semilunar valves, they're going to open up. So semilunar valves open, which means blood is ejected. Okay, blood's ejected. So for the pulmonary circuit, blood's going to leave the right ventricle, pulmonary trunk, pulmonary arteries to the lungs, right? And that's going to come back to the left atria through the pulmonary veins. Systemic circuit, blood's going to leave the aorta from the left ventricle to the entire body, oxygenated blood to the brain, to the kidneys, to the liver, to the toes, to the muscles, whatever, and it's going to come back to the right atrium through the inferior vena cava, superior vena cava, and you can even count the coronary sinus, okay? So that's pretty simple. The pulmonary and systemic circuits are fairly straightforward, okay? So systole, so we carried the electrical current through the ventricles, they contracted. The AV valves stay closed. So I'm going to go back up and talk about that. So why do the AV valves stay closed? When the ventricles are contracting really hard, we want blood to move forward. Forward meaning into the pulmonary trunk and into the aorta. We don't want retrograde flow, what we call regurgitation. So let's say your mitral valve, let's say you have a stenotic mitral valve stenosis. The valve's calcified, it's stiff, it can't close all the way. Okay? Or you have mitral valve prolapse. You have a floppy mitral valve and it can't close, and when pressure gets pushed against it, it pops open, so blood's going to regurgitate, go backwards. So backwards means blood's going to flow from the ventricles into the atria. So when you're trying to push something forward, it's like you're trying to push a car in the snow and you push, right? You're pushing. And then when you push forward, your feet are sliding backwards. Well, the car's not going anywhere. You're just sliding backwards, okay? That's probably an awful example. But that's what happens. So you're regurgitating blood flow, okay? And then after the ventricles have contracted, they relaxed, and ventricular repolarization is represented by the T wave, okay? We don't see anything for atrial repolarization because it's hidden in the QRS complex. When the ventricles are depolarizing, the atria are repolarizing, so it's hidden in the QRS complex, so we don't see that, okay? Okay, and then the ventricles contract, they eject their blood, and then what happens? Then the semilunar valves snap shut, and that gives us our S2. So S2, so our SL valves close. So the pulmonic and aortic valve are closing. When they snap shut, that's going to give us our S2 heart sound. Remember, S1 is our lub, S2 is our dub. So lub, dub, lub, dub. Okay? So we might as well talk about S3 and S4 heart sounds. Okay, so I've depicted here S1, S2, S1, S2. So lub dub, lub dub. So lub dub, lub dub. Okay, these are lubs and our dubs. It's really systole should be kind of shorter and these should be wider. It's okay. So S3 and S4, so we can probably figure what S3 is going to come after S2 and S4 is going to come after S3. This is how we're going to look at it. So S3, think of it this way. So these both occur in diastole. Okay, S3 and S4 both occur in diastole. So think about that first. Okay, let's just erase this out of the way. You guys got that down anyway. Okay. Okay, so S3 is happening right after S2. Okay, so here's S1, S2, lub dub, lub dub, lub dub. So S3 happens right after S2. Okay, so lub dub, lub dub, lub dub, lub dub. Okay, lub dub, lub dub. Okay, so it's right after S2. So it's happening early in diastole. Early in diastole. So we know in diastole, well, blood's flowing through the atria and it's hitting the walls of the ventricles. So usually an S3 heart sound, not to get into all the specifics, is usually due to, we can say, a more compliant left ventricle. Okay, so left ventricle that stretches more, so it's more compliant. Okay. Okay, and we'll talk about how a trick with this too. So S4 happens late in diastole. So S4 is going to happen late in diastole. So we can put it over here. So S4 happens latent diastole, meaning it happens right before S1. So instead of lubbed up, we have schlubbed up, schlubbed up, schlubbed up, schlubbed up, schlubbed up. Okay? I know it sounds weird, me saying that, but so this happens latent diastole. So the heart's already filling up, right? It's filled up a lot. So it's when the atria contract and push blood. So atria are contracting and pushing blood in the ventricles. The AV valves haven't closed yet. Okay? So blood is flowing into the ventricles. The AV valves haven't closed because right before S1, because right after you hear S4, if you do hear an S4, the AV valves will shut. Okay? So this is due to the ventricles being stiff. So this is very, very basic. So S4, usually it's because of a stiff ventricle. And S3 is usually be due to a very compliant or overly compliant ventricle. Okay, but they're both happening diastole. So one trick to remember this probably, I hope will help you, is the way I learned it, is think of the states Kentucky and Tennessee. So Kentucky and Tennessee. So if you have an S3, I'm going to write this, it's going to help or not. So S3, we say Kentucky, Kentucky, Kentucky. So S1 is Ken, okay? S2 is Tuck, and then S3 is Y. Kentucky, 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 Kentucky. So if we didn't have Y, the lub dub would be Kentuck, 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 lub dub, lub dub, lub dub, lub dub, Kentuck, 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 lub dub. If it's Kentucky, we have an S3, it's Kentucky, 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 Kentucky. Okay? So Kentucky, say Kentucky if there's an S3. Kentucky. So S1, S2, and S3. Right? It's state Kentucky. If you have an S4, we say Tennessee. So for the S4, it's 10. Okay? For the S1, it's nah. And S2 is, I don't know how to spell Tennessee. Tennessee. There we go. Okay, so in S4, it's Tennessee, Tennessee, Tennessee. So instead of Kentucky, Kentucky, it's Tennessee, 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 Tennessee. So if it was lubbed up, it would be Nessie, 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 lubbed up, lubbed up, lubbed up, Nessie. If there's an S4, it would be Tennessee, Tennessee. So lubbed up, lubbed up, lubbed up. Okay, so Tennessee, Tennessee. So that's an S4, that's an S3. So there's the Kentucky and Tennessee trick, which I'm sure I explained fantastically, okay? So S3, there's an overly compliant ventricle. S4, the ventricle's stiff. S3 is happening early in diastole, so right after S2. S4 is happening late in diastole, so right before the AV valves close, so right before S1, okay? Last thing I'll talk about is extrinsic innervation of the heart. So remember, this is intrinsic, so the heart is going to beat on its own, okay, because it's the leaky sodium channels in the SA node. They depolarize very easily. But remember, we can affect the heart, right? So the vagus nerve. So the vagus nerve is one of the most important nerves right in our body, and it carries parasympathetic innervation to the heart. So this can decrease the heart rate. So parasympathetic stimulation via the vagus nerve can decrease heart rate. Okay, that's chronotropic effects. Remember, we can't forget chronotropic. So chronotropic versus ionotropic. All right, so the vagus nerve has chronotropic effects on the heart. We could say negative chronotropic effects. So it slows down the heart rate. Chronos means time, chronos, like in ancient Greek, so chronotropic, okay? So that means chronotropic effects could be increasing the heart rate or decreasing the heart rate. So the vagus nerve has negative chronotropic effects. It'll slow the heart rate down. Sympathetic fibers, coming from usually T1 to T4 levels of the spinal cord, those sympathetic nerves have positive chronotropic effects, so they're going to increase your heart rate. But remember, the sympathetic nerves also innervate the myocardium, and they have positive ionotropic effects. So what's a positive ionotropic effects? So ionotropic refers to ion movement. Remember, all these nodal cells Okay, in the heart, like these cells have sodium, or all the cells in the heart, they have sodium channels and calcium channels, potassium channels. We're not going to go over all those details, but ionotropic means we're going to have those ions move more efficiently. It's like the best way of explaining it. So ionotropic effects means the heart's going to contract harder. So sympathetic stimulation of the heart will have positive chronotropic effects, and it can have positive ionotropic effects, which will increase heart rate, can increase stroke volume, which is going to increase your cardiac output, because we know cardiac output equals heart rate times stroke volume. Okay? Where the vagus nerve can slower heart rate, have negative chronotropic effects, decrease heart rate, which will decrease our cardiac output. Okay? So I know this was brief and quick, but hopefully this helps for your review.